Good morning. It is my great pleasure to introduce our speaker this morning at MHIF Ground Rounds. Dr. Carly Lodewyks did her training in Manitoba in Canada to do her cardiothoracic training, and then spent a time at Duke University to develop and hone her skills in heart failure surgery, including cardiac transplantation, as well as mechanical circulatory support. Dr. Lodewyks joined us last year, and over the last year really has set a mark with us, has helped us evolve our procurement and preoperative management of our heart failure patients and shock patients. And she is here today to speak about the rise of the machines. Thank you, Dr. Lodewyks.
Good morning. Thank you, Dr. Sun, for the introduction. Today we're going to talk a little bit about the indications for mechanical circulatory support, look at some of the latest devices we're using to support patients with advanced heart failure, and also discuss some organ preservation and perfusion systems in heart transplantation. I have no financial disclosures, but as Dr. Sun mentioned, I do have some personal ones. I did the majority of my training in Canada, where the heart failure and heart transplant system looks a lot different than it does here in the US. I did the bulk of my heart failure training at Duke, which is one of the largest thoracic organ failure centers in the world. So a lot of my practice and approaches are colored by my experience there, and I hope to share some of what I've learned with you today. We're going to start with a case. 68-year-old male with diabetes. He's a smoker. He comes in with a late anterior STEMI and an occluded ostial LAD. He has residual severe disease. He gets stented and a balloon pump is placed. Following this, his EF is 20 to 25%. He gets cardioverted for AFib, and initially there was some improvement in his hemodynamics, but now his filling pressures are elevated, his index is low, and he's really on maximum medical and balloon pump support. So your friendly advanced heart failure cardiologist calls you and says, hey, can you see this guy in bed 38 for consideration of advanced therapies? So how do we decide where we go next, and what are the important considerations for these patients? Well, obviously you need to be sure about what type of shock is playing in here. Is it just cardiogenic? Are there other factors? Which pump is the problem, LV, RV, or do you need to support both? Is there oxygenation issues, and are there clinical considerations which might impact your ability to use one type of MCS or the other? Some of our short-term MCS options that we can consider: ECMO, obviously, a historical mainstay of support; centromag pumps, either left, right, or BiMADs; intra-aortic balloon pump, most commonly femoral, but can also be axillary; and then the Impella, which we're seeing increasing use, most common these days, the CP or the 5.5. And then where do durable LVAD and heart transplantation fall in this patient's management? So when thinking about the acute heart failure patient and options for them for short and medium-term support, you must always think about what the long-term goal is going to be and what they might be a candidate for in the future. And then you can more adequately figure out what type of bridge you need to get you there. LVAD and transplant workups take time, and in the case of our patient, if we carry on with medical support, he will likely die. So we're going to start by discussing the Impella. And I went into the weeds a little bit with this because the history is quite interesting. The first pumps were actually based on this mechanism developed by Archimedes around 200 BC called the Archimedes screw, which is used to raise water out of lakes and rivers. It's a helical surface with a cylindrical shaft that's placed inside a hollow tube, and then that lifts the water up from wherever it's sitting and carries it to the top of the tube. The first Impella device was invented by this fellow, Dr. Richard Wampler, who was inspired by the Archimedes screw when he was on a trip to Egypt in the 1970s. He has an entire website dedicated to him, and was apparently referred to as Captain Hemo, which is interesting. This was his pump, the Nimbus Hemo pump, which looks surprisingly similar to the Impella that we use today, especially the console. It was also a continuous flow intravascular pump that sat in the LV and ejected into the aorta. It had a purge assembly for blood seal integrity. It had a lubrication system, and the control and power was completely from the console. It also reminded me of a different type of Nimbus for Harry Potter fans. So primarily femoral implant, but could apparently also be done direct aortic with reports in the abdominal aorta. provided 3.5 liters of flow. You didn't have to synchronize, and then LV decompression. As with many things in the surgical MCS world, the first in-human implant was done by this physician, Dr. Bud Fraser at the Texas Heart Institute, and the report about it even made it to the New York Times. His study looking at the use of hemopump in 53 patients with refractory cardiogenic shock was successfully inserted in 41 out of those 53. They saw significant hemodynamic improvements in these patients. There was minimal hemolysis and no issues with leg ischemia. 30-day survival still wasn't great with these very sick patients. So when I was doing my research, I came across this paper, a similar paper that describes a series of the hemopump use with the first other author, none other than Dr. Mike Mooney. I sent him a message inquiring about his involvement in this, to which he replied, "Wow, that was a while ago when I had hair." And so here's the only photo I could find on Google of Dr. Mooney with hair. But they had similar findings about the utility for hemodynamic support. Unfortunately, it didn't really have commercial success at the time. It was discontinued. And then in Germany in the early 1990s, there was a group that modified it more to what we see today. So with a short rotating impeller rather than the long screw, it had a mini motor on the catheter versus through the console design. They did experimental studies and then US FDA approval ultimately of the initial 2.5 in 2008 and then the CP in 2012 and so on. So we're going to talk a little about these types of Impella pumps and what our current options are. The 2.5 was the first one available and then upgraded to the CP. These are retrograde femoral approach pumps. 2.5, obviously 2.5 liters of flow. The CP, about 4 liters of flow. Approved for use 4 days in cardiogenic shock, and the primary uses are for high-risk PCI in cardiogenic post-cardiotomy shock, and then now more often in LV unloading for ECMO patients. The CP is very useful, but it's not perfect. It does have limited flow capability, especially in patients that have severe cardiogenic shock and need significant support. We would refer to them at Duke as crushing platelets for CP. It's groin access, so this does limit the patient's mobility over a period of time and increase the risk of vascular injury and bleeding. And then we often need to upsize to a bigger pump if the patient has significant shock. So what do the bigger devices look like? The initial surgical Impellas, the 5.0 and the LD, provided 4 to 5 liters of flow. They are femoral or axillary cut down, and the LD, which is the straight one here in the bottom picture, was the first direct aortic pump. Their initial approval was for 14 days. And then the newest version, or the one that we primarily use these days, the Impella 5.5, 5.5 liters of flow, that's the one in the top picture with the elbow bend in it. They got rid of the pigtail. It has Smart Assist capability, which allows for positioning and hemodynamic monitoring. Usually put in by axillary cut down, can also be used direct aortic, and the initial approvals were for 14 days and 30 days CE mark. When we look at the Impella literature, this is a study that was just published this year comparing outcomes of 5.0 patients with 5.5 patients. This was from the Impella Quality Registry. There's over 1,200 patients from 290 US centers. The Impella 5.5 had higher survival for all indications, had a higher percentage of bridge to transplant, a higher rate of successful weaning, the duration of support was longer, and there was lower hemolysis with the 5.5 patients. Thought to be related to the fact they got rid of the pigtail, positioning is a little bit easier. This was a retrospective series looking at the first 200 patients implanted with an Impella 5.5 in the US, again using the Impella Quality Registry. Most of them were implanted in the right axillary artery. Median duration of support was 10 days, but out to as long as almost 65 days. And 35% of these patients were on ECPella, so ECMO with the Impella. The overall rates of adverse events were very low, primarily bleeding in 4 patients. 3/4 of them were weaned or bridged, meaning they survived. 19% of these patients died or had withdrawal of care, and most of those were ECPella patients. So overall, 5.5 has great outcomes and low complication rates. Perhaps one of the most important emerging uses of the Impella 5.5 now is as a bridge to transplantation. It really allows us to optimize patients, especially if they have significant end organ dysfunction. If they've got pulmonary hypertension, we can unload the LV and see if it's reversible and potentially make them a transplant candidate. If that's a barrier, it allows us to reduce the vasoactive support. We can mobilize them because there's no catheters in their groins, and we can also use it for a prolonged period of time. It also impacts how we list them for transplant. So I want to talk a little bit about the listing criteria change because it significantly impacted the use of Impella and balloon pump devices in transplant patients. So the old criteria was a 3-tiered system, which really was inadequate at risk estimation in the highest category. So it lumped together this whole smorgasbord of patients: total artificial hearts, balloons, ECMO, LVADs, inotropes, ventilators, and it also didn't require objective physiological measures to justify their listing status. So the waitlist times were long, and there was increasing waitlist morbidity and mortality. In October 2018, they switched to a 6-tiered system, which essentially broke up 1A status in a more granular way. So now patients with balloon pumps and surgical LVADs, like an Impella 5.5, are given a status 2 listing, which has increased the use of the pumps and also decreased wait times for these patients. I want to throw in a little sidebar for axillary balloon pumps because I think they deserve a mention, but they're not my favorite. It is an alternative bridging strategy. It does allow for the status 2 listing, obviously provides less hemodynamic support, but there's ongoing positioning issues and they can be very finicky to manage in the ICU. If you think about it, the balloon is basically being put in upside down. And so oftentimes the fiber optic cable does not work properly in helping the balloon pump to function optimally. However, there are specific populations where using an Impella would be contraindicated if a patient has a mechanical aortic valve. If they have significant aortic stenosis or LV thrombus, then this would be a potential option. Okay, so going back to the Impella 5.5 as a bridge to transplantation, this is a study that looked at waitlist outcomes in these patients. A UNOS database study, so 464 patients that had an Impella 5.5 at any time while they're on the wait list. Median time was 19 days. It was shorter if they were initially listed, so 10 days with the Impella, 37 days if the Impella was added later in their listing course. Almost 90% were transplanted. And if you look on these graphs, the figure on the left shows the increasing use of Impella 5.5 as a bridge. So 2021, which is the furthest right, essentially the fraction of total transplant bridged is the same as the number bridged. And then in figure 2, you can see that over 3/4 of the patients implanted were transplanted off the wait list, and only a very small percentage died or deteriorated. There was high rates of transplant off the device, excellent 1-year survival, and low rates of complications you see down in the table below post-transplant. So when speaking with our Abiomed team, this was as of a few weeks ago, the world record Impella 5.5 run was 269 days with a single device as a bridge to transplant in Florida. So this would not be average, of course, but obviously it is very durable. Okay, one of the other extremely useful functions for the Impella 5.5 is direct aortic implantation, most commonly used for post-cardiotomy cardiogenic shock and also as part of planned implantation in patients that have low EF that are undergoing other cardiac surgery. It is an FDA-approved implant technique and use, provides excellent hemodynamic support in the perioperative period, and if implanted in such a way allows us to close the chest, take the patient to the ICU, and then decannulate at the bedside, so it does not require repeat sternotomy. In the figure on the left here, Abiomed has started a prospective study looking at the use of direct aortic Impellas in low EF cardiac surgery patients, and recently the Montefiore group enrolled the first patient. In the graphics on the right, this is a little schematic about how we do the implantation. So we sew an 8mm graft on the distal ascending aorta. This graft can be tunneled out either in the intercostal space, second intercostal space, or more commonly here we do it supraclavicularly. And then the device is delivered down. You can do it with the cross clamp on or off, and then used when you're weaning off bypass. When are some time when we would not use the Impella? If there's thrombus in the ventricle, obviously, as we spoke about before, if there's a mechanical aortic valve, aortic stenosis, or significant aortic insufficiency. If there's peripheral arterial disease, which would preclude placement, especially if you're looking at going axillary, significant right heart failure, LV rupture tamponade, and then obviously if they need escalated support, so right-sided support, respiratory support, this is not going to cut it. Interestingly, in the instructions for use, any kind of shunt is considered contraindicated, and now we're seeing increasing use of the Impella potentially along with ECMO in an ECPella situation for patients with post-infarct VSD in order to sort of temporize them a little bit, improve their end organ function before taking them to the operating room. So there is significant growing case report literature that this is an effective way to manage those patients. So if we think back to our case, we put in an Impella 5.5 in this patient, which allowed for completion of his advanced therapies workup and optimization of his end organ function. A little bit about Abbott and the Impella 5.5. Again, thanks to the Abiomed team for providing this data. The blue is the Impella CP use. You can see over the last 3 years or so, the CP use is pretty constant. And the green is our Impella 5.5 use, which is growing significantly, and we continue to use as an excellent tool. Okay, so we've talked about the left-sided Impella options. What about the right side? What do we have available for temporary support? So the Impella RP is a right-sided Abiomed product. It is inserted via the femoral vein. It's approved for 14 days. It can flow to 4 liters. It is a relatively small catheter that will sit up in the main PA. It has a pigtail. We don't tend to use this a lot here. Some of the drawbacks include it's a femoral access again, so if you're needing it for a prolonged period of time, it limits mobilization. And it also doesn't have an oxygenator capacity. More commonly, for temporary right-sided support, we use the Protect Duo, which is a dual lumen cannula inserted in the jugular vein. It's big, it's 29 or 31 French size. You can splice in an oxygenator, and it's not a femoral insertion. So again, allows us to mobilize these patients. And then from a surgical perspective, there's a surgical RVAD or centromag, which we do here. We sew a graft on the main PA, tunnel it out the intercostal space, and then the inflow cannula usually start with a femoral multi-stage venous. And again, this allows us to close the chest and then decannulate the patient at the bedside in the ICU, so it does not require repeat sternotomy. So to try and improve upon some of the drawbacks with the Impella RP, the Impella RP Flex was approved by the FDA about a year ago and is going to be available hopefully to us soon. This is going to be an Impella with IJ insertion, and it is a 22 French cannula, so smaller than a Protect. It will have the Smart Assist capability like the 5.5 and be able to deliver up to 4 liters of flow. So exciting to be able to get this and give it a try here. Now, what about the patient that requires biventricular temporary midterm support? Historically, the only way to do this was through sternotomy with surgical bivalve implantation, which you can see here. We've talked a little bit about the RVAD already, but you can do a surgical centromag LVAD as well with an inflow cannula either in the left atrium, more commonly probably in the apex of the left ventricle, and outflow to the aorta. The chest can be closed over these cannulas, but it does require a return to the operating room to decannulate the patient. But with these newer devices and percutaneous options, we've really entered a new era of BIVAD support. Bipella, or having a left-sided Impella and then a right-sided Impella, as one option. We more commonly use the Impella 5.5 Protect combination here. But essentially, this means we can put pumps in a patient without doing a sternotomy and leave the chest for future interventions. And so this, I was hoping to get a photo of a patient with just their IJ and their axillary site. This is one, not quite the same, but they've got a subclavian Protect there. Okay, so we have our patient on Impella support as a bridge to advanced therapies. Now, what are our what's the latest with our two options here, the LVAD and transplant. So first I'm going to talk a little bit about durable LVAD, specifically our mainstay device, the Abbott HeartMate 3. The HeartMate 3 wasn't always the only option available. The HeartWare Heart HVAD was also very popular for a period of time and considered the HeartMate 3's main competition. This was until Medtronic had to stop production and sale of the device. So in June 2021, the FDA released a statement that Medtronic had done this due to increased risk of neurological events and the potential for pump stoppage. And following that, there's been multiple recalls related to battery issues, failure to start, autolog issues. It's no longer in production, but there are still a handful of HVAD patients that are alive and out there living with these devices that you have to manage these recalls with. So really, we're left with the HeartMate 3 currently as the market share, and how do we address the two Achilles heel issues of this pump? Those being driveline infection and external power source. The patient always has to be connected to something. So for several years, FilVast or fully implanted and implantable LVADs have been proposed, but really have yet to come to fruition. And in speaking with the Abbott people, since they announced FilVast, there's been multiple acquisitions. So Thoratec was acquired by St. Jude, which was acquired by Abbott, and they had lumped the HeartMate 3 in with multiple other products. And so it really prevented them from being able to move forward in a meaningful way. Until more recently, they have now a separate dedicated heart failure team, and it's up and running, and they're starting to look at more of these questions. Since people had started to look at making the pump fully implantable, two major engineering issues have come about. One is, how do you make the pump efficient enough to work as it needs to without being connected to an external power source? And along the same vein, then, how do you have a pump that works, and how do you manage the temperature that the pump generates when it's inside the human body? So these are all things that there's lots of talk about, but we haven't really had any concrete information about where things stand in the development process yet. Despite that, Abbott has been doing some work on their other products in the use in conjunction with HeartMate LVADs, and one of those is the CardioMEMS, which is an implantable PA sensor and monitoring device, and how can it be used to monitor and potentially improve and manage LVAD patients. There was a study published looking at the use of CardioMEMS in HeartMate 2 and HeartMate 3 patients, and they found that a reduction in the PA diastolic at 6 months was correlated with an improvement in functional status, so improved 6-minute walk test and less heart failure hospitalizations. It is really a feasible functional device that can allow for not only monitoring, but potentially signal towards when a patient could potentially be weaned from their LVAD, which is another topic that Dr. Sun is very passionate about in our patients here. So there is some exciting stuff coming up. And finally, our second durable bridge, and that is heart transplantation. Really, the biggest developments in transplant have come around the use of machine perfusion for donor heart management. It has revolutionized how we manage organs. It has expanded the donor pool and the number of organs we're able to use now that would otherwise have been discarded, and has allowed us to transport hearts over much longer distances. So just a little refresher, remember that there's two types of organ donors: donation after brain death, these are traditional type donors, and donation after circulatory death. To be a brain dead donor, they have to be officially confirmed brain dead. It seems obvious, but it has to be done. For donation after cardiac death, we use the modified Maastricht criteria category 3, which is a controlled withdrawal of life support, and then you wait for planned cardiac arrest after that. In the DCD organ donation pathway, the donor usually has some sort of severe injury, neurological in nature. They don't necessarily meet the criteria for brain death, or for whatever reason, brain death testing can't be conducted. But the family and the treatment team have decided that medical therapy is futile. So once they've been confirmed to be a DCD donor in a controlled fashion with the procurement teams on standby, they withdraw life-saving care. and then you wait for the patient to have asystole. That has to happen within a certain period of time for the organ to be considered viable and for the procurement to proceed. And if it does, then the teams proceed to retrieve the organs. And talking about that time period, so this is what's known as the functional warm ischemic time. So we withdraw life support, and then the clock starts when the systolic blood pressure is less than 50. And you must have circulatory arrest within, and there's some variability in this, but generally we say 30 minutes from that blood pressure mark. If that happens, then there's a mandatory standoff period. Usually it's about 5 minutes where they listen, confirm that there's an absence of heartbeat, and it allows the teams to come in and do whatever additional prep they need to do before an incision is made. Sometimes that involves transporting the donor very quickly down a hallway, which is difficult. And then you do your sternotomy and procurement. In order to be able to use these DCD organs, there has to be a way to reperfuse the organ and assess its viability and function after it's procured. So there's really 2 ways to do this now. The first being thoracoabdominal normothermic regional perfusion, or TANRP, or direct procurement and perfusion. I'm going to talk a little bit about both. So NRP, just a brief word about that. Essentially, this means placing the donor on VA ECMO after clamping the head vessels in order to reanimate and reperfuse the heart within the donor before it's procured. These are 2 early studies from the pioneering groups in the UK and Australia, which showed that NRP has comparable results for DCD donors to direct procurement and perfusion. There was a study just published this past spring which involved several large volume NRP centers looking at the use of NRP in DCD donors versus standard brain dead donors. They found that NRP significantly increased their ability to use organs and their transplant activity and had similar 30-day, 1-year, and 5-year survival. So overall, it is an effective way to preserve and procure organs, and it has definitely been growing. Some of the advantages: it is warm blood perfusion. You can assess the heart function in the donor itself. It reduces warm ischemia because you basically get in there right away. You don't use cardioplegia and arrest the heart. You put them on ECMO and perfuse it right away. The equipment is potentially less cumbersome than all the OCS equipment, which we'll talk about in a little bit. Essentially means transporting an ECMO circuit and having a perfusionist. And it potentially is cheaper depending on the model that a center is using. Now, the disadvantages of NRP really come around the ethical debates about this. And there's 2 major issues. Number 1, the definition of brain death in many regions revolves around cessation of circulation. So when you put the donor on ECMO and restart circulation, this challenges that definition of death. The other issue is the possibility, and there's a lot of debate about this, of potential reanimation or perfusion of the brain by collaterals, even though you've clamped the head vessels, and what that could potentially mean for a donor. So this is very region specific, and I think most centers that have gone through the approval process, it is not an easy task, but it is increasing in use. So the other option post-DCD procurement is direct procurement and perfusion, and the most commonly used device for that now is the TransMedics OCS. This is cold preservation of the heart, so you arrest the heart, you procure it. It can be used for DCD or brain dead donors. We'll talk a little bit about that in a minute. You prepare it and place it on the rig, and then it's warm perfusion. The heart is restarted and transported warm and beating back to the recipient. The machine allows for monitoring of several different parameters, so you get an aortic pressure, an aortic flow, coronary flow, and a heart rate. Usually we pace the hearts. You draw blood gases to look at the metabolics and electrolytes, and then monitoring of the cardiac function aside from the visual appearance of the heart is done by arterial and venous lactates. So the theory is if the venous lactate is higher, you assume that the heart is secreting lactate, and you need to try and make some changes to optimize the organ function. This is some photos of us out on a TransMedics run during my fellowship. We had our own team at that point where perfusion would come with us and we would do the procurements. This is a picture of the heart on the machine. All of this main, I don't know if you can see my pointer. I don't think you can. The main module there, all of that is disposables. And so put it on, there's a reservoir underneath, and connect everything up, and then the electrical, sort of the control panel modules on the left. And then once the heart is hooked up on the rig and being perfused, it usually starts to beat on its own, and we use temporary pacing to pace it, usually at 80. Advantages of the OCS, similar to NRP, it decreases ischemic time, it's warm perfusion, we can assess the organ function, it has expanded our organ utilization, as we spoke about before, and it also allows for support of extended criteria donors, which we'll talk about in a minute. Some of the disadvantages, number one is cost, especially for a program that potentially has their own transmedics team and is purchasing their own module, costs about $250,000. And then the disposables for each run are about $50,000 each. The equipment is cumbersome. You have to take a lot of stuff. You need more people. And so you have to make sure you have planes and ambulances and cars that can fit everything. You need perfusion or preservation support. And then from a clinical standpoint, these hearts tend to be a little bit more edematous, a little bit more boggy, and have a bit more RV dysfunction than a regular brain dead donor. This was at the end of a run, and these were the 7 things we always had to count. We had 7 things with us. So the rig itself, the base, which is the wheels, the huge box, which was like this tall, that has the disposables that we used a dolly to carry around, the run bag, the red run bag, the drug bag, and the cooler. So we did not travel light. A little over a year ago, Transmedics sort of capitalized on this theory that they could probably do these procurements more efficiently. And so they created a Transmedics procurement service. And so that's what we're using here now. Basically, that means you identify a DCD organ, you can call Transmedics up and say, hey, we have an organ, can you go get it for us? They employ their own staff of procurement surgeons and preservationists. They use their own modules. They fly out, do the procurement, and then the preservationist flies it to you. So it makes it a lot easier, especially for smaller programs like ours, from a manpower perspective and a sort of planning perspective to have them do it this way. And this service really has taken off. Along those lines, back in April at ISHLT, Transmedics announced that they had purchased their own aviation company. And so now they're going to be able to use their own planes and their own pilots and not be reliant on private planes, which can be challenging to go out and do this. So they have big plans, and I think it's going to be really interesting to see where this goes. So what is the evidence surrounding the use of the OCS? So there's been 2 major studies. The first one was published in June of this year, and our group was a part of this study. This is the DCD heart study, where they looked at DCD using the Transmedics OCS and brain dead cold storage in 180 patients at 13 centers. The adjusted 6-month survival, DCD was non-inferior to brain dead donors, and the overall survival out to 12 months was similar. There was more moderate to severe PGD in the DCD group, which isn't unexpected given you have the period of warm ischemia that occurs at the beginning of the agonal phase before it gets flushed with cardioplegia, but it did not affect patient or graft survival at 30 days or 1 year. And the second study is the EXPAND trial, and this has not yet been published but was presented at ISHLT last year. It is looking at the use of OCS management for extended criteria donors. And what exactly is an extended criteria donor? Most commonly, it would be a heart that's located far away, where you anticipate the overall ischemic time or cross-clamp time to be more than 4 hours. It also includes donors that are older. Perhaps they have a long reported downtime or an uncertain cause of death. Maybe they have some LVH, the heart function is not quite normal, where they would maybe be considered borderline to accept. This was a single-arm trial. They did use brain dead donors from 1,800 patients, or 1,800 brain dead donors, and the extended criteria brain deads had an 88% freedom from severe PGD, and there was no significant difference in survival at 2 years compared to the regular brain dead controls. So both of these studies led to FDA approval of the OCS device for DCD donation and also extended criteria brain dead donation. The furthest that I went on a procurement was from Durham to Puerto Rico, which is about a 4-hour flight. Interesting logistics of that one, but it was an extended criteria brain dead donor based on that time. The heart did very well and had no major issues. I wanted to spend just a few minutes talking about some of the other machine perfusion options, both in use and currently under investigation. And these are in the hypothermic machine perfusion realm. So the OCS is warm beating. This is hypothermic perfusion. The ex vivo system is currently available, though not in the United States, used mostly in Europe and Australia. That heart is transported cold and arrested with continuous perfusion of a special perfusate solution. It's being used a lot for hearts that are further away for extended ischemic time. This is the Life Cradle, which was developed by a company called Bridge to Life. Again, also hyperthermic machine perfusion, kind of plug and play. You put it on the box, you don't have to monitor it, it gets perfused. It is not in use clinically yet, but it was just sold to Transmedics along with the EVOS, which is a lung perfusion machine. So it'll be interesting to see what Transmedics plans to do with this in the future. So what about regular ice? And really, regular ice has fallen out of favor since the Paragonic Sherpa Pack transport system came onto the scene, which we're now using here. Essentially, the donor heart is suspended in a canister full of preservation solution that's kept between 4 and 8 degrees, and then that canister goes inside this cooler. And there's never any contact or any potential contact of the organ with ice itself. The cooler, it's not active. It doesn't actively cool, but it's passive. It maintains fixed temperature, and it allows for continuous temperature monitoring within the canister. Recently, the Guardian Heart, which is the registry that Paragonics maintains of Sherpa Pack implanted hearts, they published a paper looking at the 1-year outcomes of 569 adults, so it was a comparative study, 255 Sherpa Pack organs versus 314 organs transported on ice. The Sherpa Pack showed a 67% reduction in severe PGD. When they propensity matched, this relationship still existed. In hearts that had long ischemic times, they had significantly reduced the use of MCS, severe PGD, and better 30-day survival. And the use of ice storage was an independent predictor of severe PGD, increased almost 3.5 times. Another important study that they conducted was a cost analysis. It looks like a simple cooler, but it costs a lot of money. It's about $15,000 for 1 unit, and none of it is reusable. So in the cost analysis, and you can presume based on the improvements we see in PGD, they found a benefit of almost $30,000 in using the Sherpa Pack. So there are obvious significant advantages, and I think here the surgeons have been very happy with how the hearts come out of the transport container and how well they work after we implant them. They do have other products, so this was at the Sherpa Pack's the one in the middle. They also have a lung guard, which is the blue one, and then a newer liver guard. This was a procurement where we were doing all three. And even further, more recently, the group from MGH announced that they had done a procurement from Alaska to Boston, which is a 7.5-hour travel time, with just the Sherpa Pack. So really, it's starting to push the boundaries of what we can do with cold storage, and we'll have to see how things kind of balance out with the use of Transmedics for these extended criteria donors for time. The longest flight that I know of to date from Durham has been to LAX, so a little shorter than that. Okay, finally, I don't think this video is going to work. No. So this is a heart that's working very poorly. Just take my word for it. So what do we do for a patient that has severe biventricular dysfunction and is not a transplant candidate? So there is a new type of total artificial heart. This is the ASON Carmat total artificial heart. Its blood contact surfaces are made out of bovine pericardium. It uses 4 bovine pericardial valves to increase the hemocompatibility and decrease the need for anticoagulation. It has a pulsatile mechanism that mimics native ventricular contraction and decreases shear force. And the pump outputs are auto-regulated based on preload pressure changes within the device. So I want to show you this little video from the CARMAT website because I think it does a really good job of explaining how the device works. Oops, there we go. Okay. I don't know if there's sound. There's fancy music, but it's okay. So the ventricles are removed, and then you sew on these cuffs. And basically allows it to put the plate on and click the device in place. And then you attach the outflow.
This one's unique in that the blood contact is little tissue. So there's pericardial sacs there as opposed to polyurethane, which is what the other total artificial hearts were.
So because it's auto-regulated and it adjusts based on the pressures inside, you can have some up titration and down titration of flow depending on patient need and cardiac output. Okay. Okay, so the first CARMAT implanted in the United States was put in at Duke in July of 2021. This was a 39-year-old man that had come in with ischemic cardiomyopathy and heart failure with severe coronary disease. He was waiting for his CABG and had a VF arrest. He was placed on ECMO. He then was transitioned to an Impella 5.5, but had ongoing issues with arrhythmias and right heart failure, as well as severe end organ dysfunction. He was felt to be too sick to transplant at that point, and so he was submitted for the CARMAT early feasibility trial. Importantly, one of the biggest, I would say, downfalls of this device is it's very large and requires a sternal body to vertebral body distance of 12.6 centimeters. This man was big and was able to accommodate that. It was implanted per their protocol. It was put in their auto-regulatory mode right off the bat, which allows that beat-to-beat change based on the filling pressures. It was maintained in this mode for the entire run. In the first 30 days, there was only one alarm, and that was when the patient had bared down and it just resolved itself. The anticoagulation initially is heparin, but then transitioned to daily enoxaparin and aspirin, so does not require warfarin. And then as part of the study, they looked at his platelet function and von Willebrand factor and compared with people that do not have LVADs, they normalize over the course of the run. He also corrected his end organ dysfunction, had no major complications, and was eventually discharged from hospital. This is a picture of what the main screen looks like and the parameters that they monitor. And 4 months later, we transplanted him, and he did very well in their 8-month follow-up. He had normal graft function and was home with his son. So this CARMAT total artificial heart, compared to other versions of a total artificial heart, has a potential for fewer strokes or neurological events based on that biocompatibility factor. Also potential for improved patient quality of life with the ability to auto-regulate based on cardiac output needs of the patient. The early feasibility study was actually stopped for a period of time because there was some adverse outcomes and concerns about issues with quality control of that product. They've fixed those issues and the trial is ongoing again now, and they've been enrolling primarily in Europe. So we'll see where that goes. Okay, so in summary, the world of surgical heart failure is changing very quickly. We have a lot of new devices to use and to use in different ways, but I think that really the art of it and the challenge comes in deciding on who to use what in and when. that's it. I'll take any questions. Yes, perhaps.
Thanks for that great talk. I was just wondering if you look a little bit more into the future, what's your thoughts on xenotransplantation?
Yes. I think it's amazing. Obviously, there's a lot of work being done, and we get periodic updates on, I think they just did another implant, right? There's a second patient, yeah. And so I think it has great potential. I mean, any way that we can try and improve the access to organs in a reliable fashion is great. And the fact that they've been able to even have some success for a period of time with that is an incredible feat of engineering and medicine, really. So obviously the big problem with the first patient was this virus that had been found, this pig virus that had been eventually found and was the ultimate cause for that patient's PGD and death. But so how they manage that in the future going forward. But I think it has incredible potential.
The concern is what Carly said, is we don't have 100% guarantee that we don't have some new pathogen jump from pig to human, and that's the concern. I think for all of us, and the immunology is also very complicated. They keep talking. It's like peeling an onion, right? You get layers. There were 10 genes that were adjusted in these that pig. 10. 7 of them were knockout genes, and then a few of them were just adding human genes into the pig. So, I mean, that concept of the island of Dr. Moreau gives some of us the EVs on that, to be frank.
I think the latest one has 69 genes edited now from that company.
Yeah, it's concerning. I mean, you know, there's excitement about it. There are other areas that people are working on for taking decellularized, you know, taking a human heart and then decellularizing and then growing it back with your own DNA, your own stem cells. That has, there's some kind of bioreactors that people are working on towards developing, you know, auto transplant organs in a sense. My personal feeling is that probably will get traction faster than us solving the problems of xenotransplants. It's my opinion.
Is there any concern for the long-term durability of the DCD hearts?
Potentially, but we just haven't seen it. I mean, in the studies that have been done up until this point, obviously the DCD hearts are sort of newer. In the time frame, we don't have the same long-term follow-up that we do of decades of DBD heart transplantation. But aside from the initial upfront PGD, we just don't see the longer-term effects on graft function at this point in a meaningful way. So hopefully that continues. Most of the time, we can manage that initial PGD. Patients on ECMO for a few days, the heart function improves, and we decannulate them.
As a follow-up, how much increase in availability of organs has this actually translated into?
Good question, and I don't know what the,
Actually,
do you know
the data is that it's
what the latest is?
it's actually complicated because it's region by region. So at least a 20% increase already, period. But one of the things about donation is that our donor after brain death donation has been relatively flat over the span of the last 30 years. There may be some slight incremental improvement in access to it, but that number has been relatively flat. But donor after circulatory death, that number actually has been increasing 20% per year, but it depends on each region. Some regions are growing faster, some regions are growing slower. In our region, LifeSource, we're at about 20% per year growth year over year. Now, at some point, that's going to flatten out. But so the number right now of total, how it adds to our donor pool is still a moving target right now.
And I think part of that is the fact that more centers, especially smaller centers, are being able to do DCD procurements with the transmedic service.
Right.
So in regions where prior they just didn't have the capability to do it. Now there's resources and availability of the transmedics team for if they have a DC organ for them to get it. So the variability is
Virtually nationwide, almost 90% of all procurements done on OCS is done by transmedics now. Even Duke's, Columbia's, who have their own teams, logistically, it makes more sense for them. The incremental cost for transmedics to do it is overridden by the training, the complexity, and the logistics of getting teams there and back with all that stuff. So their program is been a resounding success so far.
What percent of our transplants are DCD?
Small, I would say
it's
like
probably like that same 10 to 20% range maybe.
we use the
It
OCS
varies.
system almost 50% of the time right now. We also use the Sherpa Pack now, but the interesting thing is the brain death procurements that are of distance. We've been using the OCS system because that's what it's approved for. But as we get more and more comfortable with the Sherpa Pack in how it actually is very good at long distances now too, that'll probably change that ratio because it is a little cheaper.
Carly, your first slide, I think Duke had 143 heart transplants. So I'm just curious, how did they get such a huge program? And then what's the future for our program here, you know, with this new hospital being built and everything? Are we sort of limited because of competition with the U and Mayo? Is it a geographic thing? Or is it just we just have a small footprint and this is kind of our sweet spot and we're just gonna keep our volumes around here?
Yeah, good questions. I think Duke's program really stems from a long history of heart and lung failure excellence. Dr. Carmel Milano, who is currently he's now the new chief, but he's been head of the heart failure LVAD program for many years, has really worked to grow that program, and they have a huge network of referral, huge. So patients come from all over the country. They move to North Carolina to get their transplant. I mean, obviously they have the local volume, but there's a huge referral network there. And it also is surrounded by an exceptional team. I mean, it's a team of, 3 surgeons did 146 transplants in a year. So an incredibly dedicated surgical team. They have a very excellent anesthesia and critical care group that are used to managing very sick patients, and they also will do a lot of high-risk transplants. So patients that would be turned down elsewhere that come to Duke for their transplant. They also have been very quick to embrace some of these newer technologies. So they're the biggest center on both of those transmedics trials. And so part of that, just expanding what they can do for their patients, I think has been huge. As far as our ability to expand here, I think when you compare us to other centers, especially the Mayo Clinic, I think our patient population is very different from what the Mayo Clinic population is. I don't think we're necessarily in competition with them. I think that our growth really stems upon trying to see more acute heart failure patients and do more outreach. And I haven't been here that long, but in my discussions with Dr. Ekman about this, it sounds like, like many things, COVID really impacted our ability to get the patients here from outside hospitals and maintain those relationships with cardiologists in the community who would previously have sent us their shock patients. So I think trying to work on that relationship is important. And I think we have seen some growth in that. I mean, last year we did 9 transplants. I think this year we've done 12 so far, and it's, October, November. So hopefully we'll get a few more in. It would be nice to see up closer to 20 in the next year or so. Any other questions?
Thank you.